Hi, everyone. Welcome back. I'm Dr. Michael Miyazaki here, and this is part 2 of our Regen series of webinars. What I want to talk about today is really the technique of using this bioactive material, Regen, to place successful direct bonded restorations. And so the techniques are not that different, but I think there's some little tweaks you want to make to the technique in order to ensure success. So I just want to go through that today. So we're going to take this tooth. This is the lower left molar. In this case, we're placing a rubber dam. When you can place a rubber dam, it is advantageous because you get such great isolation. I had a patient 2 weeks ago. We were doing the upper right second molar, and the patient's cheeks were just really big. And I will tell you, it was tough. We had to do a MOD restoration on the upper right second molar. And I put a rubber dam on the second molar, and the good thing about having a rubber dam there was that the ring of the rubber dam actually helped to hold the cheek out of the way, because I tried taking a mirror and was trying to reflect the cheek back out towards the buccal, and it was just a fight. So having a rubber dam clamp back there and the rubber dam just made it so much easier. So when you can, and if you're so inclined, using a rubber dam does make it easier. Why? Because it does get the cheeks out of the way, gets the soft tissue out of the way, maximizes our visualization of the tooth, and it keeps the debris out of the patient's mouth, especially the amalgam. A lot of patients, when they have an amalgam removed, they know there's some mercury in there, so if they like to have that kept outside of their mouth so they're not even swallowing it. And it prevents contamination of our restorative material as we place that restoration. So in this case, we've got this MO area where there's decay, there's a fracture in the tooth that we see going down there, and we know we're going to end up fairly close to the gum line. So as we prepare that tooth, we get that red stuff, the blood coming up, and we know we cannot bond if there's a lot of moisture down there, saliva, or if there's blood down there. We're just not going to get a good bond of our direct restorative material to the tooth. So we need to control that. And we've mentioned this before in other webinars, is one of the things that I like. And it's not just for the anterior aesthetic area, but I use it throughout the entire mouth today. I don't use the brown ferric hemostatic agents. I only use the Kwikstat free. So the Kwikstat free is clear, but I find it to be just be very effective. So I would take my Kwikstat free, I would just rub it down there, not really scrubbing the tissue. I'm not trying to irritate the tissue, but I just get the Kwikstat free down there where the bleeding is. And remember, we've got the aluminum chloride, the magnesium, and we've got the surfactants. And so the surfactants just help the agents get into those blood vessels that are bleeding. We get better penetration because we've lowered the surface tension. I rinse that off. And most of the time, once we'll stop the bleeding in that area. It is an astringent also, so it kind of causes the tissues to pucker up a little bit. But so we don't have to. But if we get a little bit of blood down there, we just hit it one more time, rinse it. So once I get that bleeding under control and I get the crevicular fluids under control and my rubber dam's keeping everything out of the way, now another trick is that if I take my phosphoric acid down there and I get the phosphoric acid on that tissue, even if I stop the bleeding, when the acid from that phosphoric acid hits the tissue, what do we see? We see reactivation of the bleeding. So another trick you can do, and I'll do this if I'm working in an area where the tissue is just very friable, or maybe I'm way subgingival in an area, and just by looking at the tissue, I get blood in that area percolating up. Instead of putting phosphoric acid down there, I'll use Clean and Boost. Now, Clean and Boost is nitric acid. So the nitric acid will clean the tooth, but it will also etch the enamel, but it's more gentle on the organic part of the tooth, so the dentin, and it will etch the enamel, but it doesn't cause the soft tissue to bleed. So if I carefully brush that on, I get into the dentin area and I get it onto the enamel, and I'm just real gentle where that tissue is bleeding. I let it sit there for 20 seconds and then rinse that off. What that'll do is that will condition the dentin. It will, to remove the smear layer, it will etch the enamel, but it will not, as you see down here on the bottom photo, it will not cause that tissue to bleed again. Whereas if I place phosphoric acid down there, it would bleed. And so one of the things I want to point out is the Regen adhesive, we call the universal adhesive, but it does not self-etch. So you do have to condition or etch the tooth before you use Regen. Why is that? Well, we showed this in previous webinars, is that the Regen with the BioGlass 45S5 in it will neutralize acid. So imagine if we made the adhesive bottle that contained the Regen BioGlass, the bioactive portion of that adhesive, we made that solution acidic, it would just be neutralized because the BioGlass is in there also. So a couple tips. If you are having issues with the tissue bleeding, then try Clean and Boost. It's a nitric acid. It doesn't elicit the same kind of bleeding as when you put phosphoric acid down around the friable tissue area. And if you're going to use the Bioactive Regen adhesive, you want to make sure that you condition the tooth because it is not acidic, because it would neutralize that acidity. So a couple things to think about. Now, if I'm in an area where I'm concerned about having post-op sensitivity, we can place Desensemax. Desensemax helps you to eliminate sensitivity. It prevents MMP generation, which is the enzymatic activity that breaks down our hybrid layer. It's antimicrobial. It provides fluoride. So all these things, and it re-wets the tooth, so we get better penetration of our adhesive down into those tubules. All these things will help prevent sensitivity. So what you do is you take the Desensemax desensitizer and you shake the bottle up for about 3 seconds just to get everything well mixed. Take it, a little microbrush. I just put a little microbrush or a tip like you see here, either one. If you don't have the tip, use a microbrush, put it in a well, brush it down into the preparation, leave it there for about 5 seconds, lightly air dry it off. And now you have that desensitizer layer over the dental tubules. Now take your Regen, and again, you've got the BioGlass in there. So shake it up for about 3 seconds just to mix everything up really well. And then take your microbrush applicator and just kind of liberally apply it. You know, you want, just like with any adhesive, you want to get the adhesive, the resin, and the BioGlass to completely cover the preparation. And then give it time to soak down into those dental tubules. So don't just apply it and then lightly, or quickly air dry it off. Liberally apply it, all right? So you can get it, it can even look thick. And then I think a key is take your air, lightly hit your adhesive with the air. Now what that's going to do is it's going to gently evaporate off your solvent. And as the solvent evaporates off and leaving the resin behind with the BioGlass, now you're going to have a thicker layer. But if you get in there and all the resin's there with all the solvent, it's a very thin, non-viscous layer, right? And if you get in there and you blow it with really vigorous air, there's a possibility that you're going to blow all the resin and the BioGlass off of the preparation. So the way you do it is get in there, and I come in with my little air syringe, and I gently blow the air over my prep. That's going to evaporate off the solvent. So now the resin and the BioGlass kind of thickens up a little bit. I don't want it to be too thick, but now there's very little chance I'm going to blow it all off because it's more viscous. So now I up the air pressure, and I just hit it vigorously with a lot of air for about another 10 seconds. And what I'm trying to do is I'm trying to blow it really thin and try to make sure that all the water is evaporated off. So I hit it, and you'll see the adhesive kind of blow off to the side, but because I've thickened it up a little bit with the 5-10 seconds of a gentle air, I'm not going to blow it all off. I'm just going to thin it out really well, and I just keep hitting it until I see no movement of the adhesive layer. Now I'm done with the adhesive. I then sometimes will either light cure that. If the area has bleeding or moisture, I might light cure that, or I'll put my flowable composite in there. Why the flowable? Because the Regen flowable composite liner is a reservoir of that BioGlass 45S5. So I'll just lay that over the adhesive. Like in this case where I've got a rubber dam there, I might just thin out my adhesive layer. I may cure it, or maybe I'll just put my flowable down and then light cure the flowable and the adhesive all in one step. Now remember, if I've got an area where we have that decay, that adhesive layer is really thin. And if I want to reservoir that Bioglass 45S5, then I might take that flowable composite and create what we call an open sandwich technique. Have that flowable composite exposed. So, we have on the left-hand side, we have kind of the closed sandwich, the ham and cheese croissant. But you can't see the ham and cheese because it's inside the bread. On the right-hand side, we've got an open sandwich where you can see all the fillings in that sandwich. So think of that when we talk about open sandwich. So on the left-hand side, if I was doing the closed sandwich technique, kind of think of the croissant more or less with the ham and all the goodies hidden away. The yellow line is the floor of our prep, and that's where the adhesive would be. And then what I do is I put some flowable, but you might with this technique not expose the flowable to the gingival floor margin, and then you would put your favorite composite, sculptable composite, over the top. All that Bioglass reservoir in that flowable composite is sheltered from the oral environment, right? But remember, what we want to do is we want to expose that flowable composite at the gingival margin because it has the ability with its bioactivity to neutralize the acidity in that area, and it helps to attract the calcium and the phosphates and release fluoride in that area. So we want to have it exposed. That's an open sandwich technique. So what I'll do is I'll put my adhesive down, then I'll put my flowable down, so I know that the bottom floor of that gingival portion of my prep has the adhesive and the flowable composite, and then I'll put my sculptable composite over the top. That's the open sandwich technique. So now that blue line, which represents our flowable composite liner, is exposed to the oral environment. Then we can get in there and cure. And when we cure with our pink wave curing light because it has the ability to cure to a greater depth. It's got the large head, so it covers the entire occlusal surface of that molar because the lens is so big. It's got a very low profile, so I can get it all the way back there to the second molar, and the patient's not going to have to open up too wide because the profile of that curing light is so low profile. And it's got the quad wave, so we have everything we need. We've got the power, we've got the proper wavelengths, and we have the ability to get this curing light all the way back to that second molar. And remember, with the near infrared wavelength, we're actually decreasing our shrinkage stress. So I get my adhesive and my flowable composite liner all cured, and now we can put in our sculptable composite. And what you see here is our phaser. Our phaser is our composite warmer. Now, if you don't warm your composite, I would encourage you to try warming your composite because the more goodies, the more fillers a manufacturer puts in their composites to make it more resistant to wear, the thicker that composite gets. And I always relate it to you are trying to butter your toast, and you pull the butter out of the fridge and it is rock hard, and you slice it and you kind of fight the butter, and then you take that hard butter and you try to spread it across the toast and you just tear your toast apart, and that the butter doesn't get into all the nooks and crannies of your toast very well unless that toast is still very warm. But if you took that butter and you warmed it up, almost made it a margarine consistency, your knife would just go right through that butter, you'd spread it out, and that butter would just soak into the little nooks and crannies of your toast. And that's basically the same thinking. Is heating the composite allows you to manipulate it much easier. And so if you're able to manipulate it and it's able to get into all the nooks and crannies and adapt better to your prep, you're going to have fewer voids, hopefully no voids. It's going to improve the physical properties of your composite. It's going to decrease the volumetric shrinkage again. A lot of you have seen the research about the benefits of warming your composite. But to me, what the biggest advantage is that you take that composite that's normally thick, and now it just comes out of your composite gun like that warmed butter, and you just spread it out, you contour it, and it just makes life so much easier. So now we get in there, we sculpt it, we light cure it, and we have our restoration all completed. Now, a lot of times when you have a class 2 restoration, you've got a cavity maybe on a mesial of a second molar, and what do you see on the distal of the molar in front of that? You see another area of decalcification. We call those the kissing cavities, because one cavity develops on one tooth, and where that tooth touches the tooth next to it, you might get a secondary decalcification or cavity on the other tooth. So When I see that, sometimes I'll get in there and radiographically I won't see it as a radiographic decalcification, and I'll scrape that decalcified tooth and it just seems hard to me. And so I think, okay, do I want to prep that tooth out or do I want to give it a chance to heal? So then what I do is we kind of do the remin, I call it the remin open sandwich technique, where we put our bioactive adhesive down, and then you can see that all the way up to that contact point where that, kind of where I have the red there, that's where it's decalcified. And I put that bioglass flowable composite all the way up to that contact area because why? It's got that bioactivity. And we might be able to remineralize that area of decalcification by putting that bioactive flow composite liner all the way up to that contact point. So I cure that and then put the sculptable composite, which shows up in green, over the top of that, just for the aesthetics and the wear properties that I desire in a tooth like that. So I call that the kind of the remineralization open sandwich technique, where I'm taking the bioactivity from my flowable composite liner material with the bioactivity it has because it has Bioglass 45S5 in it, and I'm trying to help the other contact heal up so I don't have to restore it. So here's a tooth, and again, it doesn't have a tooth mesial to it, but I'm just showing here, you see the decalcification and a previous composite that was placed in this tooth. And here we clean it out. Now we're going to place our direct composite. So in the box form, I'm going to place the composite, the flowable composite liner material that's bioactive with the 45S5 glass, bioactive glass. Over that, we're going to place our composite, our just regular sculptable composite, but that flowable composite liner with that bioactivity would then make contact with the tooth mesial to it, and you can see that the aesthetics comes out just fine. You can't tell where the flowable composite is versus the sculptable, but we know we have this great area now of bioactivity. So imagine if there was a tooth mesial to that tooth that was making contact with that restoration, how that restoration might help that tooth heal up. So by following these techniques, we can prevent sensitivity, because none of us want to place a direct composite and have the patient come back a week or two later saying, ever since you placed that composite, that tooth is sensitive, and it was never sensitive until you placed that. So, follow the techniques that I talk about. What we're trying to do is we're trying to create these restorations that have greater longevity, right? Because we start out with a small filling, and then it gets secondary decay, and now that filling gets larger, and then it gets secondary decay once again, and now that filling may get larger or may necessitate us to go from a direct restoration now to an indirect. And maybe at that point the nerve goes bad, so then we have to do a root canal and then a crown. Maybe 10 years after that it has to be extracted, and maybe an implant goes in that area. But we see this kind of happen very often in our practices, where we start with a small filling, maybe when the patient's young, but when they're 50 or 60 years old, we end up having to pull that tooth out, and we go into the implant stage. So think about, if you were taking care of your family, how you'd want those restorations to have that longevity. And again, the Bioglass 45S5 lends itself well to this. And I tell the patients, I go, before we would have a cavity. A cavity is basically an area where there's acid on the tooth, and it kind of creates this hole in the tooth. So now we have to go in, we have to clean out that hole and then fill that cavity up, that where we're missing tooth structure, with a filling. The filling fills in that hole. In the past, we would fill that up with amalgam. Basically, the amalgam was just an inert material that would fill that cavity up and make it so you could chew with it, but it would protect the tooth. But then you get another cavity in that tooth because it's a hard area to keep clean. Well, today we have a filling material that helps prevent that recurrent cavity from happening. And so now this filling is going to help the tooth heal up. Once we place it, it's going to help to prevent another cavity from occurring in that same area. And I've had a lot of patients, once we tell them this, that they go, wow, you know what, I would pay more for that filling material if it helps prevent cavities. And I always tell the patients, you're not going to pay any more for this, but in our practice, we want to use the best materials we can. And so the materials we use are the ones that help to prevent added expenses down the road. And the patients really appreciate that we are using a bioactive restorative material. So we look out for the health of not only their oral cavity and their teeth, but also the health of their pocketbook. And if we can make it so that they don't have to pay for another restoration, that is of great value. Now, who wants to get numbed up and have the drill in their mouth? Nobody, right? So I think it's very important that we're able to offer our patients these restorations that can last longer. So it helps us to differentiate our practice, helps to increase the value of what we provide in our practice, and that's really what we want for our patients, is we want the very best. So whatever we would do for our family members, we want to be sure that we offer our patients the same level of service. So that's the recipe right there for long-lasting restorations. You can take a screenshot. Again, thank you for joining us for this YouTube webinar. Hit subscribe. We're going to be bringing more information. I'll be sharing more of the cases that I do and how I use the materials in my own practice. And we've got a great community here. Thank you very much for joining us. Take care.